So the second disease, that is pulmonary anthracis, that is why we also call it a wool sorter disease. And this wool sorter disease, it is caused by inhalation of the anthracis spore. So when a person inhale these spores enter into the respiratory tract, where it germinate and produce a bacteria, and bacteria produce a toxin, and that toxin will cause a disease. Bacteria can also enter from the respiratory tract to the nearby lymphatic tissue. And when the bacteria enter into the nearby lymphatic tissue, it will cause hemorrhagic lymphangitis. Hemorrhagic lymphangitis. As the name suggests, hemorrhagic. So there will be a bleeding. So it is hemorrhagic lymphangitis. And it can also cause hemorrhagic mediastinitis. Mediastinum in hemorrhagic mean bleeding, bleeding in mediastinum. And if it is untreated, then the mortality rate is about 100%, because there will be a internal bleeding, blood loss, and the patient die because of blood loss, as well as bacteria enter into the blood. So there will be a bacteremia, so patient develops septicemia as well. So septicemia, bleeding, these are the major risk factors for mortality. So that is why if you don't treat the pulmonary anthracis, then there will be a chances of death, 100% mortality rate. So what you can find on the patient, first of all, when the patient get this pulmonary anthracis, there will be a sign and symptoms just like flu-like symptoms, first of all. And then there will be a cough develop. Cough may be of a bloody cough, or we call it hemoptysis. Hemoptysis. This is a medical term for blood in sputum or cough. Hemoptysis. Hemoptysis. So patient may present with hemoptysis, shortness of breath, and the patient may have a symptoms of septicemia, high grade fever, hypotension. We have just discussed about this septicemia, hypotension symptoms. And when we perform the X-ray, the thing which we can see, this is the mediastinal widening. Till now you don't study, I think till now you didn't study this radiology. So anyhow, just look at these X-rays. This is actually the mediastinal, we call it mediastinal widening. So mediastinal widening, it is one of the clue. But remember, mediastinal widening, we have lot of differentials: sarcoidosis, uh, tuberculosis, lung tumors, okay, autoimmune diseases, as well as some mass in the mediastinum. So we have lot of differentials for this mediastinal widening. But if a patient have pulmonary anthracis, then there is a mediastinal widening which you can see on the chest X-ray. Along with that, because bacteria also entered into the alveoli. So within the alveoli, it will cause edema, as well as it enter into the pleural cavity, where it cause edema. So when we look on the X-ray, so there will be a edema here. This whole lung, it is vanished. This area is also vanished. So there is a pulmonary edema, as well as the pleural effusion. Actually, it's a pleural effusion, not edema. Sorry, it's a pleural effusion, because for pulmonary edema, there should be a curly B lines. So we don't see the curly B lines on X-ray. So this is actually the pleural effusion. So in pleural effusion, here you can see the lower lobe, the lower lobe, it's completely, it's vanished. Like it's you can say it's transparent, because there is a fluid. The whole lower lobe, there is a fluid. So there will be a pleural effusion. Here you can see. So you can also see these symptoms in your patient with pulmonary anthracis. So there is a mediastinal widening. Here you can see the mediastinum is widened, as well as there is a pleural effusion. Although not only anthracis, in anthracis there is a this kind of condition, we also have other conditions as well. Like I told you, even pneumonia can also cause this kind of condition. So remember, we also always correlate the labs with the patient history. So if patient history is suggestive, then we can consider that the patient have inhaled anthracis. Or we can also take a we can also take a sample from of a sputum. We can culture the bacteria, and after culturing we can get to know that whether it's a anthrax or whether it's some other disease. So we have different differential diagnoses like pneumonia, I told you, mycoplasma pneumonia, viral pneumonia, Legionnaire's disease, cytocosis, these, and coccidiomycosis. These are actually the fungal diseases. Telluremia, I told you, that is actually caused by the tick bite. Q fever, histoplasmosis, malignancy, sarcoidosis. These also the differential diagnosis of anthraxis because they also cause the same sign and symptoms. So now I told you don't need to remember these differentials, but just you should know we have a lot of other diseases as well which can cause the same condition as anthracis. So the treatment strategy for this post-exposure prophylaxis of anthrax, I told you fluoroquinolones or ciprofloxacins, these are the first line agent even for the treatment or post-exposure prophylaxis. So we need to give this ciprofloxacin for up to 60 days. I told you up to 2 months we have to give the treatment. The same for example, if there is acuteness anthraxis, again we need to give for at least 60 days the same treatment, ciprofloxacin. For in inhalation anthracis, which is associated with bioterrorist event. Okay, so bioterrorism, if some bioterrorism is there, so again ciprofloxacin we need to give, or alternatively we can give doxycycline. So this picture you can see here, this is hemorrhage. Q, which Q? This one? You mean this Q? Okay, okay. This is a medical terminology. Q we use for every. So 100 mg every 12 hours. Q mean every. Okay, so these are the Latin terminologies which we use in medicine. For example, QID, this is 4 times a day. If we write QD, it means once daily. Okay, if we write BID, it is twice daily. Yes, so Q mean every, and sometimes we also use this word E and there is a slash, it's mean with. Okay, so when we write a patient history, so instead of writing some complete words, we use some abbreviation which are commonly used in history writing as well as for writing a prescription. Okay, so Q mean every. We have other terminologies like stat mean immediately. Okay, so you study these terminologies. PO mean per oral. PO per oral. Okay, PO. So orally, we need to give oral drugs per oral. Okay, so this is inhalation anthrax. You can see here. First of all, look at the lungs. It is completely hemorrhagic. And here you can see this is the trachea. Okay, so you can see this is hemorrhagic. It's a bleeding here. It also a lung. this is the heart, and this is the lung. Sorry, this is the lung, and this is actually the trachea. You can see here the bleeding. Okay, so this is the inhalation anthrax that can cause the mediastinal bleeding or hemorrhagic mediastinitis. And in the brain, here you can see this is the meninges, so it can also cause a hemorrhagic meningitis. Hemorrhagic meningitis. So here you can see all the meninges. Actually the brain is black. What is this black? Black is actually the hemorrhage. So this is also a lethal manifestation, or you can say the like these are the conditions or lethal conditions of inhalation of these anthraces. Okay, so how we can identify this bacteria in the lab? Okay, so the most common, we take a patient sample, the lesion sample, we take a biopsy sample, or we can take a sample from the lesion, especially from the cutaneous side. And I have told you that when we take a sample, we can grow this bacteria very easily. And I also told you that when we take a sample from a patient, clinical sample, these bacteria do not form a spore. Why this bacteria don't form a spore? Because bacteria is getting all the nutrients, so there is no requirement of spore formation. So they do not sporulate in a clinical sample. Okay, even during a culture. So because culturing, we are providing the nutrition, so that's why they do not grow. But when we look at the spore, so spores are oval and centrally located. And when we and when uh, and when we actually grow this bacteria on a blood agar, so the colonies, they are large, grayish, and non-hemolytic. Okay, non-hemolytic. They are grayish, large, and non-hemolytic. This is Bacillus anthracis. Non-hemolytic, you can see this is the blood agar. So none of these two bacteria, they actually metabolized or use the blood. And when we look at under the microscope, so they may be formed as a chain. Here you can see this is a chain, or they may form as a single bacteria. They may form as a single bacteria, or they may form a irregular chain like formation. And their both ends of bacteria, these are the blunt ends, this one, blunt ends. So when we see this bacteria under a microscope, okay, so they have blunt ended bacilli. Usually they occur usually single, or either they form a long chain. Okay, and remember, these species, they are non-motile. They are non-motile bacteria. So you can see here there is no any kind of flagellum. So these bacteria are non-motile. Okay, so they also they are encapsulated. They also positive for encapsulation. For encapsulation, we grow the bacteria on bicarbonate agar. Bicarbonate agar. So they produce a positive encapsulation test. This is also a confirmatory test for this bacteria, Bacillus anthracis. So these are identification points for these bacteria. So here you can see these are the spores, oval spores, and this is actually the bacilli, gram-positive bacilli. They are formed either in chain, either single, or either they may be present in the pair form. Okay, so the treatment, I think we have already discussed that treatment is we can start a ciprofloxacin. If you see here, the main drug of choice is ciprofloxacin. But remember, in some cases, if a patient is, if the bacteria is not responding to the first line treatment, that is ciprofloxacin, or if a patient is resistant against these drugs, then we have another drugs like rifampin and vancomycin. Rifampin and vancomycin. So we can give these two drugs together. If a patient is having a multi-drug resistance, or if a patient is resistant, if this bacteria is resistant to ciprofloxacin, then we can start rifampin and vancomycin. This is also the alternative choices if a patient have, if a bacteria have a uh, resistant resistance against the medicine. Last thing which I need to mention here, that is prevention. How we can prevent, how we can prevent this bacteria. So the prevention, it depends on the lifestyle mean that we know that when we go out, we should have to wear the shoes, and we don't need to touch, or even if we have some injury in the soil, so we should need to take a vaccine first, especially those people who are working in especially the labor work, you know, the labor who has a who always have who always have a contact with the soil, or a person who is working in some farm, cattle farm. So all those people, they must need a vaccine. So first of all, we can prevent this disease by giving a vaccination. So giving a vaccination, so vaccination can prevent this spread of this disease. So this is primary prevention. But once a patient is exposed, and once the patient is exposed, first is vaccination. Second is once a person is exposed, that is post exposure. So after a exposure, we can start ciprofloxacin, or we can give rifampin or vancomycin or clindamycin to uh, cure the disease or to kill the bacteria. So that was a prevention of Bacillus anthracis. Now let's start another bacteria, that is Listeria. So Listeria is a genus. Listeria is a genus, and Listeria monocytogen is actually the species. As a general the general explanation about this Listeria species, so all the Listeria species, they are slender, short, gram positive bacteria, gram positive rods. Okay, they are gram positive non spore forming rods. So most of them, they occur as diplobacillus. They form a diplobacillus. When we culture the bacteria, they usually occur in the form of pairs, diplobacillus. And some of them, they form a short chain. They form a short chain. Listeria monocytogen, or this Listeria species, they are also known as intracellular parasite. They are also known as intracellular parasite. Why we call them intracellular parasite? As I told you, they are very small bacteria. So they require our cell to grow. So these bacteria, after entering into the body, they enter into the cell. They enter into the cell and they multiply and they grow within our cell. So that is why we call them intracellular parasite. Okay. So Listeria monocytogens, they are the intracellular parasite, and they are highly spread in the nature. So These parasites cannot be seen in blood. These parasite, because they are intracellular parasite, so when we see this, most of the time the bacteria is seen within the cytoplasm of the host cells when we take a tissue sample, because this bacteria is a intracellular parasite. So these listeria species like human, although they are limited exposure, but they may be a direct exposure or maybe an indirect exposure. Sometimes this Listeria monocytogen, they form a colony, but they do not cause any disease. So Listeria is present, but there is no any disease. Other characteristic of Listerias are Listeria species are catalase positive, and they also show a motility, a tumbling motility. This is also one of the distinguished feature. Listeria species are catalase positive, and uh, they actually display a tumbling motility in a liquid medium. I think I have a picture I show you later. So these characteristics actually distinguish it from coccus, streptococcus, and corynebacterium. These characteristics, they actually separate these Listeria from other, because it is catalase positive, and these are motile. Listeria monocytogenes, they are motile bacteria. Okay, so what is the epidemiology of this bacteria? So this bacteria, it is Listeria monocytogen is the only Listeria monocytogen. It is the only species which infect human, because most of other Listeria species, they do not cause a disease in human. Okay, although other Listeria species, they are present in animals, but in human only Listeria monocytogen cause a infection. And most of the infections, they are foodborne. They are foodborne. Most of the infections, they are foodborne. What do you mean by foodborne? After eating or drinking the contaminated food, foodborne diseases. So especially the dairy product, meat and milk. By drinking contaminated milk, meat and dairy product, as well as this bacteria also colonized in vagina. So from the vagina, this bacteria can also transmit into the fetus, and once it enter into the fetus, it will cause meningitis. It will cause meningitis. So this is their epidemiology. So Listeria monocytogen is the only species that infect the human, and most of the infections, they are caused that are foodborne after eating or drinking some contaminated products. As I told you, the dairy product. So dairy products involve eggs, milk, cream, and cheese. Even cheese and cream can also, if they are contaminated, then it can also spread from these products as well. The meat, the meat, it also like may have uh, this bacteria. And one of the important feature, or you can say resistant feature of this bacteria is this bacteria can even grow at 4 degree 4 degree temperature. And we know that 4 degree temperature is our refrigerator temperature. You know, our refrigerator temperature is between 2 to 8 degrees centigrade. So even at 4 degree, this bacteria can replicate. So that is why even if you place your meat, your dairy product, your poultry products into the refrigerator, this bacteria can still grow in that temperature. Okay, understood class?
Yes, sir.
So
Yes,
as
sir.
okay, so as a general pathogenesis, this bacteria it actually produce a listeriolysin. I think here I can explain you better. Okay, so the pathogenesis of this bacteria, it actually, as I told you, it is a intracellular parasite. It's an intracellular parasite. So it enter into the macrophages by phagocytosis. So here in this picture you can see here. So this bacteria enter into the macrophages through phagocytosis, and once this bacteria enter into the into the macrophages, the bacteria produce a listerolysin O. Listerolysin O. So this listerolysin it break down the phagosome, the wall which is around this bacteria, and then the bacteria become a free bacteria within the cytoplasm of the macrophages. So after this, the bacteria multiply within the cell. Which cell? Within the macrophage, it multiply, it replicate, and along with that, the listeria acquire a tail, that is actin filament, that is made up of actin filament. So the bacteria it acquire these actin filaments from the cell, from the macrophages, and after the multiplication and after getting this actin filament, these actin filament help the bacteria to propel and infect other cells. So what happened? This bacteria it acquire these the tail of actin, although this is not the pure tail, but these are the actin filaments will help the bacteria to push the bacteria to the surface or outer surface of the macrophage. So when this bacteria move, it it looks like just like a comet. You know comet, stars. When the star, how to say, dead star at the night, we know that some if some comet is moving, so we can see one comet here, and then there is a like kind of red in color, red tail. You know the dead star. So just like a dead star or just like a moving comet, this bacteria it actually show this type of movement or this type of picture when we look at this bacteria within this macrophage. And once bacteria reach to the surface of the macrophage, the bacteria it actually make a pseudopod, and then these pseudopod help the bacteria to enter or to infect other cell. So bacteria replicate within the macrophage and then it will be expelled. It form a pseudopod. This is pseudopod. It form a pseudopod, and through the pseudopod this bacteria enter into another macrophage, and again other macrophage will be infected and bacteria replicate within this macrophage. Okay class, do you have any question? We have about 3 minutes. Please, if you have any question you can ask till now, so later we will continue this topic in our next class because we have only 3 minutes. I need to take your attendance. Please be quick. Okay, so roll number 802,
Present.
3, 4, 6, 8, 8. 8 is present. 9, 10, 13.
Present.
मेरे को आदत है होने चला वन दीवार
14,
मैं पहले पुजान तक मैंने अब तक कुरान चलावन देना
14, 17, 18,